It's 2 o'clock. Welcome everybody again to the afternoon session. The topic of this session is surgery, anesthesiology and intensive care. And I'm glad to welcome all of you which are interested in this field of healthcare. And I think we'll start. Maybe.
Good afternoon. My great pleasure is to invite to Professor Viesturs Boka to deliver the state-of-art lecture, Safe Surgery, Saves Lives, Global Patient Safety Challenge. Please, Professor Boka.
Thank you. This is a rather serious topic, but I myself, I would like to start. I'm very fond of New Orleans, Dixieland and funeral music. Rather serious events, but they play Dixieland in these topics. And I will try to speak about this rather difficult topic as safe surgery in a little bit light and tricky way. Let's see what will happen now. The safe surgery save lives. Yes. First of all, Paul Gauguin, 200 years ago, painting. Where do we come from? What are we and where are we going? The Lancet Commission on Global Surgery declared that 8 up to 32% of diseases can be attributed to surgical treatable conditions. And a lot of operations are performed yearly. But 5 billion people without access to safe and available surgical care. About 143 million additional surgical procedures needed in low and middle income countries each year. And what are the technological trends in surgery today? Minimizing invasiveness of surgical procedures, simplifying the surgical procedures as much as possible, make it shorter, and minimizing the human factor. I will speak later a lot of human factor in surgery. Complications in surgery. It's a bad story. 1 in 10 patients over 65 suffered the major complications after surgery on aorta, lung, or gut, and up to 18% of them died. And the difference in cost, you see, 3 times more expensive to treat patients with complications. Causes of death in the United States. Yes, United States, very far we can speak very much about the situation in the States. The third leading cause of death, ranking by yearly deaths. Something is terribly wrong, because if we see the 10 years difference, no significant change in rate of preventable errors. Something is terribly wrong. And if we compare risks in healthcare with other industries, for example, bungee jumping, chemical manufacturing, commercial aviation, that we see that in healthcare more than 1 death per 1,000 encounters and more than 4,000 serious surgical errors every year. What do newspapers say about it? Health workers hide errors out of fear of lawsuits. And the main question remains today, how to not get sicker in the hospital? I would like to start with some myths about mistakes. I don't make mistakes, so I don't need this. Others make mistakes because they don't pay attention to try harder. We can't mistake-proof everything, so why bother? So, George Bernard Shaw, success doesn't consist in never making mistakes, but in never making the same one a second time. You can never make the same mistake twice, because the second time you make it, it's not a mistake, it's a choice. Few words back. Let's see what are our roots of surgery. Always make new mistakes today. But surgery starts with Sushruta. I would like to speak about Sushruta because often in these topics about history of surgery, people like to speak about Hippocrates. But 600 before Christ, that means 600 before Hippocrates, Sushruta in India. Look, trocars, prostatectomy, hernia surgery, laparotomies, management of ileus, perforated viscera, and so on. We can call him father of surgery. But how old are mistakes of surgery? You see surgical instruments, left side Sushrutas instrument, right side instruments 200 years ago. Very similar. Nowadays, do the instruments themselves make surgery safer? You see modern instruments. Are they very different from those 200 years ago? I don't think so. If we are looking development of our operating rooms, 19th century, 20th century, second part of 20th century, yes, we see development. Nowadays, extremely extraordinary situation in our operating theaters. Virtual and robotic surgery. These pictures are very exciting. If we look at our doctors, are they doctors really? You see them, they are physicians. But nevertheless, I would like to say that virtual reality for surgery today, that means surgical training, education, eye-hand coordination, surgical planning, modeling and visualization, surgical testing and rehearsal, and surgical delivery. That's okay, but what about mistakes and errors? Adverse events in general and robotic surgery. Robotic surgery can cause errors also, and combination of multiple causal factors lead to safety hazards and incidents. Inadequate experience, lack of training, inadequate coordination between hand and foot movements, incorrect part placements, cable connections, electrocautery settings, inadequate troubleshooting, inadequate system instrument checks, and so and so. So what? Where are we now? It must be accepted that human errors will occur at a level between 1 in 1,000 or 1 in 5,000 events, and that will increase in stressful situations. That is our starting point today. Benjamin Franklin, 200 years ago, said, "Clean your finger before you point at my spots." Everyone will make mistakes. What are types of safety? We see medical safety, environmental safety, equipment safety, blood safety, laboratory, electrical, and then surgical safety. That means that surgical safety is only one item in this complex box of safety tools. Surgical safety. One of famous Latvian politicians some 10 years ago said, "Nothing special." Yes, nothing special in this consent of patient in writing, proper identification of patient, proper identification of parts to be operated, checkups, not foreign body left inside. Why do it happen every day? Some general definitions. Adverse event, an injury caused by medical management rather than the patient's disease. Complication, it comes outside of the doctor's control because patients are different in healing power and predisposition to complications. Medical errors mean the failure of a planned action or using a wrong plan to achieve an aim. Top errors that cause defects. Step was forgotten, something was done incorrectly, procedures not followed, adjustment and setup, everything required, assembly omissions, a part was forgotten or wrong part was included, and so on. Types of errors, action-based. And we can remember famous American writer and psychiatrist Samuel Shem, who said, "There is no body cavity that cannot be reached with a number 14 needle and a good strong arm." Yes, but it can lead to action-based error. Nevertheless, prevention of action-based errors includes implementing safety precautions, standardizing techniques, building technological duplication into systems. The second type of error, decision-based. Due to faulty knowledge, and these are more difficult to identify and correct. Prevention of decision-based errors, decrease reliance on memory through algorithms and computerized decision support. Simulation trainings, guidelines on also use of cognitive aids during crisis, emergency situations. And that type of errors, number 3, leading root cause of serious adverse events, communication-based errors. Safety interventions implemented in operating room, safety checklists, pre-operative briefings, use of structured communication and teamwork training. CNN 5 years ago published shocking medical mistakes in the States. Treating wrong patient, operating wrong body part, 30% of all adverse events. You can imagine operating the wrong body part. Wrong surgical procedures, retained surgical items, waking up during surgery, wrong postoperative management because look like tubes after operation and drainage. So, surgical procedures on the wrong patient, wrong site, and wrong side because of poor communication regarding surgical plan, imaging errors, failure to use site markings, incorrect patient positioning, surgeon fatigue, multiple surgeons, multiple procedures on the same patient, means simultaneous operations, emergencies, and unusual patient anatomy. What about retained surgical items? Incorrect surgical count, or it not performed, unexpected intraoperative factors, emergencies, more than one surgical team, long operation, intraoperative blood loss, more than 500 milliliters. But what is interesting, 80% of cases of retained sponges occurred when the counts were reported to be correct. What about risk reductions? A lot of meetings and world congresses have been held about this topic. One of them was 2017. And what were the topics in this Congress? Clean care, safe surgery, research for patient safety, reporting and learning from mistakes, education, technological improvement in the safety topic. And what are conclusions? 3 waves of innovations in patient safety. Technical advancements, standardizing procedures, high reliability organizing. These are 3 waves which can reduce patient mortality. One example of such surgical safety checklists. Before operation entry checklist, what to check, identification, procedure, consent. Then surgical pause before operation timeout. Again, what to check, blood loss, expected duration of operation, have the scalpels and plates been tested, and so on. And the 3rd checklist, written checklist, leaving the operating room. What to check, name of the procedure performed, count the instruments, have the samples that were collected been properly identified. It should be done in every operating theater in each country, but it doesn't happen every day. Top barriers implementing the patient safety system in surgery. Patient safety is not considered a top priority. Inadequate staffing and work overloads, costs of technologies, resistance to change, and culture of blame. Current healthcare culture is punitive in nature. Whose error? By patient, staff, both of them, physical, mechanical, electrical. It's very interesting that 66% errors because of patient actions also may contribute significantly to medical errors. Yes, history is just new people making old mistakes. And 10 types of human mistakes: forgetfulness, slowness, misunderstanding, wrong identification, lack of experience, willful, obstinate, surprise, and also, of course, sabotage. 4 axioms in this case. Every error has a root cause, every cause has a solution. One unwillful error is a miss, repeated error is a crime. Error can be prevented with everyone's initiative in the system. We are speaking about human factor, characteristic of mistake makers, portrait of surgeon. It was painted 569, Netherlandish painter. You see the characteristic of surgeon of those times. Temperate and moderate disposition, well-formed hands, long, slender fingers, not inclined to tremble, deep intelligence, but not audacious disposition, well-grounded in natural sciences and also in philosophy, He should know logic well to be able to understand what is written and to talk properly. What about surgical stereotype 2015? Are you a physician? No, I'm a surgeon. Stereotype surgeon described by Dr. Kathy Hughes, a man confident and brash, charismatic, commanding, cuts first, asks questions later. The best cure is cold, hard steel, sometimes wrong, never in doubt, one of the good old boys club, and so on. Is that typical for surgeons nowadays? Who knows, but Dr. Kathy Hughes thinks it's so. If speak seriously, surgeons' emotional experience in their everyday practice, responsibility for complications, feeling guilty every day, mortality meetings are experienced as a way to find who was responsible. A major problem in surgery, it's no culture of errors. Intraoperative complications are most distressing events. Surgeons describe fear and panic. Up to 9% of surgeons report concern that they had made a medical error in previous 3 months. 9% of surgeons. High risk of burnout rate up to 40%. Every surgeon knows it is simply a matter of time before the next complication or mistake. Often the only person who knows what really happened and why, it's surgeon himself. To be or not to be. The greatest mistake you can make in life is to be continually fearing you will make one. And Royal College of Surgeons. Is the surgical career right for you? Specialist knowledge, good communication skills, eager mind, manual dexterity and physical skills for performing an operation, extensive experience of preoperative and postoperative care, ability to adapt a changing environment, leadership skills, inspire confidence in others, and ability to support your team. That's it. Surgeons traditionally require eyes of a hawk and the hands of a lady. And in the end, top safety concerns for 2018. Information management in health, electronic health records, unrecognized patient worsening, clinical decision support, result reporting and follow-up, antimicrobial stewardship, patient identification, behavioral health issues, and processes to improve safety and quality. One of the main topics nowadays is cybersecurity in healthcare, because in healthcare, malware attacks are more than just IT delirium. 83% reported cybercrime attacks. There are some examples what we can do to improve safety in healthcare and also, I think, in surgery. And at the end, thank you for the attention, and again, Benjamin Franklin. By failing to prepare, you are preparing to fail. I wish you a good practice, no mistakes. Be safe. Don't be afraid of mistakes, because human factor, everyone makes mistakes in one event of 1,000 or 5,000. Be in 1,000, I wish you. Thank you.
Thank you, Professor, for a wonderful lecture. Question from the auditory. According to your lecture...
I have made mistakes, a lot of myself.
My question to you...
It's a pity, but nobody knows it. But we are speaking about reporting of these mistakes. We can learn of others' mistakes, not only of our mistakes ourselves.
One brief question. According to your lecture, exist 3 types of medical errors. What's your opinion? Who of them dominate?
I think it's communication failures. Because of bad communication follows wrong steps. I think it's the human factor, and we can communicate, and in written forms also. Written checklists and communication. That's because I think we shall wait a very long years and safety never will be 0%. 100%.
Thank you. And now it's time to start, continue our session. And before I'm asking to start first speaker, I want to explain rules of our session. 7 minutes for the presentation and 3 minutes for discussion. And now I want to ask the first speaker, who is Anna Udre, with topic management of pancreatic cancer in a specialized hepatopancreatobiliary center, short and long-term outcomes. Please.
So hello everyone, my name is Anna Udre and I'm the 5th-year medical student at the University of Latvia. And today I would like to present our study about management of pancreatic cancer in specialized hepatopancreatobiliary center and short and long-term outcomes. Pancreatic adenocarcinoma is the most frequent malignancy of the pancreas, and surgery is the only potentially curative treatment. And according to American Cancer Society, the 5-year survival rate for patients who do not undergo the surgery is 7%. And for those whose cancer has been detected at early stage and they have undergone the surgery is 27%. And for those whose cancer has been spread to surrounding tissues is 11%. The aim of our study was to share our experience in surgical management of patients with pancreatic cancer at the Department of Surgery at Riga East Clinical University Hospital between the years 2014 and 2017, and analysis of short and long-term outcomes. Altogether, 49 patients were included into the study who were operative with curative treatment, and management of the patients was provided according to National Comprehensive Cancer Network guidelines, and we were analyzing surgical procedure, lymph nodes, complications, and mortality rate. From all observed 49 patients, 65% were women and 35% were men. And patients were classified by AZA score. And as you can see, almost 49% of patients scored AZA class 3. 22% of patients had class 2. And 20% of patients had class 1. The most common type of surgical procedure was pilorus preserving pancreaticoduodenectomy, which had 33 patients, and 11 patients undergone the spleen non-preserving pancreatectomy. The mean operation time was approximately 3 to 4 hours, and mean intraoperative blood loss around 470 milliliters. The goal of the surgical extirpation of pancreatic cancer is to reach the R0 resection, and it was achieved in 84%. The mean tumor size was approximately 4 centimeters, and around 20 patients were classified as having T3 and T4 tumors. The morphological examination revealed that 86% of patients had ductal adenocarcinoma, and 8% had neuroendocrine tumors, and 6% had other type of tumors. The most common complications were postoperative complications were intra-abdominal abscesses, pleural effusion, and delayed gastric emptying. And the overall complication rate was almost 31%. The overall ICU stay was around 4 days, and total hospital stay 17 days. And from all observed 49 patients, 54 died due to the cancer, 2% patient died in inter-hospital time, and 9 patients were lost to follow-up. And analysis of cancer-related mortality shows that 71% of patients reached 1 year survival, 2 year survival reached almost 24%, and 5% reached 3 year survival rate. And the most frequent type of the pancreatic tumor was pancreatic adenocarcinoma, with the highest mortality rate during the first 12 months after surgical intervention. And analysis of complications and short and long-term outcomes could provide a better understanding of this disease and change the treatment of strategy. And to achieve better outcomes, management and follow-up of the patient should be provided in specialized centers.
Thank you. Questions?
If we see results, not very excellent long-term results, yes?
Yes.
But what do you think improvement of pancreatic cancer treatment, is the perspective of technological improvement in surgery or skills or something other? Medical therapy, radiotherapy, what are the future of pancreatic cancer?
It depends on everything, on surgery, also from to medications, to everything.
Yes. But in your study, also you operated radically tumors T4, yes?
Yes.
It's rather big tumors. And so the 1 year survival, 70%. Do you think the indications for these operations with T4 tumors are right?
It depends from the surgeon who does it.
In your study, neuroendocrine tumors were operated in 4 patients, that's right?
Yes, 9%.
What kinds? What types? Histological types?
As I'm not sure, but as I remember, there was insulinomas and gastrinomas, but I'm not sure about it.
And how do you think in this situation, if patient is diagnosed insulinoma, obligatory is need to perform this pancreatectomy, or is possible to perform pancreatic saving surgeries?
I think it's obligatory to perform.
No, for not most, but for some neuroendocrine tumors, it's enough only enucleation. That's right? My comment for the future, my recommendation, neuroendocrine tumors are absolutely different group.
Yes.
Okay. If no more questions, thank you. And the next speaker, the floor will be risk factors and prevention of anastomotic leakage after rectal resections in cancer patients. Sabina Dranova.
Ladies and gentlemen, professors, chairmen, dear colleagues, good afternoon. It is really a pleasure for me to be here, and great thanks to Scientific Committee for accepting our topic as oral presentation. First of all, I would like to stress out that Colorectal cancer remains one of the most common malignancies worldwide, with about 1 million new cases annually and nearly 5,000 deaths each year. Colorectal cancer is the third most frequent neoplasia in both sexes, combined in Western world after prostate and breast cancer. Approximately the same epidemiologic trends are in our country. Around 30% of all colorectal cancers are diagnosed in the rectal anatomic site. And surgery remains the most important treatment option for rectal cancer. The history of rectal cancer surgery has shown a continuous evolution of techniques and technologies over the years, with the aim of improving both oncological outcomes and quality of life of the patients. Since the introduction of mesorectal excision as a standard treatment of rectal cancer, the rate of sphincter-saving surgeries with low anastomosis increased significantly, resulting in increased leakage rates. The aim of this study was to define some risk factors for anastomotic leakage and to report clinical consequences of leakage after rectal resections, followed by TME in rectal cancer patients. Between January 2010 and December 2014, about 600 patients with rectal cancer were admitted to the Department of Abdominal and Soft Tissue Surgery Lateral Oncology Center at Riga East University Hospital. Total of 249 patients underwent radically curative elective open mesorectal excision with following anastomosis. Surgical resection technique remained constant because most of the radical resections were accomplished by only 2 surgeons. The radical surgical approach included high ligation of the inferior mesenteric artery with autonomic nerves and plexus saving. Vascular control was also very important for adequate lymphadenectomy and for tension-free anastomosis, as well as total mesorectal excision for tumors located in the middle and lower rectal thirds. A partial mesorectal excision with a distal resection margin of 5 cm was considered sufficient for tumors assigned to the upper third category. Straight anastomosis with stapling device was performed routinely, but a colonic G pouch was fashioned in selected patients after TME. Pelvic cavity was drained routinely with non-suction drains. Protective ileostomy or protective transverse colostomy was performed in 37 patients at surgeon's discretion. Anastomotic leakage was suspected if one of the following clinical signs occurred: gas, pus, or fecal discharge from the pelvic drains, peritonitis, fever, or lack of cytosis. Endoscopy, contrast enema, or computed tomography scan was performed if leakage was suspected. Patient characteristics, details of surgical procedure, the histopathologic parameters of the tumor, as well as postoperative outcome were documented prospectively, and all data were collected in a digital file retrospectively. The following parameters were included in the statistical analysis: demographics such as age, sex, body mass index, SS score, smoking habits, and alcohol consumption. Tumor characteristic size such as size, tumor localization, histopathologic details, and also treatment details such as operative time, colonic G pouch, presence of protective stoma, and endoanal tube placement. Logistic regression was used for univariate analysis of the prognostic value of these variables. All variables that showed p less than 0.1 were also entered into a multivariate model. So here are our findings. 126 were male and 123 were female patients. Median age of the patient was 66, ranging from 24 to 91 years old. Univariate analysis showed that patient age was borderline significant. Excessive alcohol consumption was also associated with increased anastomotic leak rate. Both tumor localization and tumor grading were factors associated with increased risk of anastomotic breakdown. Neither T-stage nor end-stage of the tumor were statistically significant. But preoperative chemoradiotherapy had an impact on anastomotic healing. Analysis of variants identified it as high significant. In multivariate analysis, absence of stoma and endoanal tube were associated with a clinical anastomotic leak. Mortality due to septic complication was 11%, which is 2 out of 18 patients. And so to conclude, patients with bulky and low-located rectal cancers are at a high risk of anastomotic leakage. A preventive stoma and endoanal tube significantly decrease the rate of clinical leaks and subsequent reparation after TME. And thank you very much for listening.
Thank you for a nice presentation. Do you have any question for our audience? I have one question about protective stoma. It was not in all patients, but only in some patients, as
Yes.
the truth. How you can, when you defend that these patients need to have stoma and this patient doesn't need to have stoma, where was indication for stoma?
It was absolutely due to the surgeon's decision. If there was considered that the patient has a higher risk, for example, a male patient because of the smaller pelvis, also some female patients with a bigger or lower located tumors. The lower location, the higher the risk, so it was considered to the surgeon.
And in your results was that if patient had this stoma, so the leakage was decreased at the end.
Yes. So we found out that stoma is protecting from the higher incidence of the leakage.
Thank you.
Colorectal surgery in the case of cancer, I think it's elective surgery, yes? And the average hospital stay was 17 days. How can you explain so long stay in hospital?
It's long. Yeah. First of all, I think it's connected to the fact that most of the patients were older age patients. Most of them were 70 plus patients, which healing is already not so fast as the younger patients. Also, it depends on the fact how surgeon how quickly the gastric motility and everything comes, and I think it's most of all because of the age of the patients.
Yes, but our population is older and older from year to year, and I think that it's the reasons are in the healthcare system and organization of it, and different levels of hospitals. And I don't think that in specialized centers we have to treat patients 2-3 weeks in the case of elective surgery. But it's another study. It's a study of healthcare organization. Your study was excellent and brilliant, and my congratulations.
Thank you.
Yes, the next presentation, late results of colon cancer resections in obese patients. The same topic, but in obese patients. Yes.
Yeah. Okay, so good afternoon. My name is Mantas Judinskas. I'm from Faculty of Medicine from Lithuania. And as you see, our study was associated with colon cancer and resection, particularly in those patients who have BMI larger than 30, and its late results. And before I begin, I'd like to congratulate you with your bronze medal in these Winter Olympic Games, and also wish you all the best for tomorrow's competition. Bring that medal home as well. Yeah, and yeah, so going back to our topic, as the literature shows, laparoscopic colon surgery is thought to have significant benefits for patients compared to the laparotomy surgery approach, and these benefits include decreased postoperative pain, decreased length of hospital stay, decreased recovery time, and improved cosmetic appearance after that. Nevertheless, late results remained not so really clear, and there's a discussion if higher BMI is associated with what's perioperative outcomes of laparoscopic colon surgery. So, we decided to compare late results between laparoscopic and open methods treating colon cancer in obese patients who have their BMI larger than 30 kilograms per square meter after 1 year follow-up in Vilnius University Hospital Santaros Klinikos. Yeah. So, first of all, a retrospective analysis of 107 patients was made. Later, this group of patients was divided into two smaller groups, first group A, 35 patients who got laparoscopic surgery. The second group consisting of 72 patients who were operated by the open approach. Then analysis of demographic data was made, and main measures included pre-operative, intraoperative data, and later post-operative outcomes. After the operation, a survey via telephone was made. It was a questionnaire given to patients in order to evaluate their quality of life after the operation, also their defecative function and their satisfaction with operation, whether they like it or not. And yeah, so, but unfortunately, we only managed to gather 77 patients from Group A, those who were operated laparoscopically, and almost 82% of patients from Group B. Group B was, as I mentioned before, open surgery. And finally, statistical analysis was performed by using Microsoft Excel and SPSS programs. Yeah, so what were the results? As you see, Group A had significantly longer length of surgery compared to the Group B, particularly 176 minutes compared to 152 minutes, and that this difference is statistically reliable. Although Group A spent approximately 6 days less in hospital than the Group B, and Group A lost approximately 3 times less blood compared to the Group B, which were operated by open approach. Moving on, these results are from that telephone survey, and from here we see that BMI was tended to decrease more in Group B. 52.4% of patients had decreased BMI after the surgery, compared to 40% of those who were operated laparoscopically, although this difference was not significantly reliable. But as we see here, the satisfaction with operation from Group A, those patients who got laparoscopic surgery, was much higher. Most of them were satisfied, and Group B, one-fourth patients were either moderately satisfied or even dissatisfied with operation. And also, yeah, and also the condition of after operation. 74% of patients from Group A said that their condition after operation was quite good, and none of them said that it was bad. While we see that almost 80% of laparotomically operated patients said that they were feeling bad after the surgery. Yeah. Moving on, here we see that work capacity after operation. That means that they were able to perform as much as they were used to before the operation. Was not changed in the laparoscopically group. That means that they were after the surgery they could do what they were used to doing. Although Group B, more than a half of these patients felt that their work efficiency decreased after the surgery. Yes, so what are the conclusions? We can assume that laparoscopically treated patients were more satisfied with operation and were more likely to regain their preoperative work capacity. So laparoscopic surgery for colon cancer is associated with better prognosis and perioperative outcome compared to the laparotomy group. And nevertheless, obese patients still remain a significant challenge, especially in those groups where they have a BMI larger than 30. So that's the challenge for surgeons, as this high BMI is associated with worse perioperative outcome. And no doubt that more research is needed to properly evaluate late results of different types of treatment in this area of surgery to be able to cure these patients better. Yes, so here are my references, and thanks for your attention. That's it.
And how did you calculate the blood loss during both surgeries?
I myself didn't do that, but it was...
Because average blood loss was 100 milliliters. How it is possible to measure such small account?
Well,
I think this is approximately.
Yeah, it's approximately, absolutely approximately, yeah.
And maybe then is no...
You should answer how it's possible. It is possible.
Yeah, no doubt.
In your presentation, the blood loss during laparoscopic surgery was less than in open group. How do you explain such differences?
Because the wound is bigger when we operate in the open approach. Because as we operate laparoscopically, we make less wounds and less intervention.
I ask one question. In these two groups, laparoscopic and open surgery, did you compare tumor size and tumor progression? Are they similar in both groups or not?
Yeah, that's a great question. We had that information, but for this particular work, we put our attention to different parts. We didn't evaluate the tumor size, so we could do that in the future, I think.
Okay,
yeah.
you can do it in the future, because I saw in your results that the recurrence rate was much higher in open group. You have 12 recurrences, in laparoscopic only 1 recurrence, so it's probably tumor size was bigger, and that's why you had such these differences. Yes.
We should do that in the future, yeah, of course.
Question from Antwerp.
You mean from laparoscopy to the open?
Did you have in your trial, okay, did you have any conversion cases in laparoscopic group, from laparoscopic to open conversion?
Well, I'm not 100% sure, but as far as I know, there weren't those. But I may be mistaken. I cannot say that 100% sure.
Okay, according Color Second trial, Color Second, very popular trial around the world. Conversion rate was 17%. Maybe you have not a very high sample size in your experience.
Yeah, maybe that, and maybe I didn't evaluate these measures. Yeah, that can be that.
Thank you.
Thank you.
Okay, thanks.
Thanks. So next presentation, please. The next presentation is monitoring of hypercoagulability by thromboelastography in bariatric surgery. Kristina Kopczynskiene.
Good afternoon, dear colleagues. My name is Kristina Kopczynskiene, and the title of my presentation is Monitoring of Hypercoagulability by Thromboelastography in Bariatric Surgery. The study was done in Hospital of Lithuanian University of Health Sciences in Department of Anesthesiology. And increasing prevalence of morbid obesity has augmented the demand for bariatric surgery, which is so far the most effective and durable therapy in achieving weight loss and improving obesity-related complications. However, there are also potential risks among them. Deep vein thrombosis and pulmonary embolisms following bariatric surgery does not exceed 2%, despite application of methods to prevent these complications. Thromboelastography provides assessment of whole blood viscoelastic properties from the beginning of first fibrin's transformation to the end of fibrinolysis. Over the last decade, TEG has gained significant importance in the management of high-risk bleeding populations, liver transplantations, and certain other conditions. Growing quantity of studies, improved technology have led to wider use of TEG in other fields of hemostasis. Among them, evaluation of hypercoagulability in perioperative setting. Further studies are needed to determine the ultimate role of this method for prediction of hypercoagulable states and postoperative thrombosis. Briefly introduce your main principles and parameters of thromboelastography. TEG assays were performed with thromboelastography hemostasis analyzer system. A small amount of blood sample is poured into cylindrical cuvette, which gently oscillates forth and back continually, simulating slow venous blood flow. As the blood starts clotting, the resistance of the motion is transmitted to the pin, and its oscillation is recorded. The resistance is related to the strength of the clot and is analyzed by a computer, which creates graphical representation. And main parameters of TEG. R time is the onset of blood clot formation, the period from the placement of blood sample to the initial fibrin formation, represents plasma clotting factors and circulating inhibitory activity. K time and alpha angle represents speed of clotting and correspond mainly with fibrinogen concentration. MA is maximal distance between two diverging branches and represents fibrin and platelet number and function. Is maximal amplitude is represents quality of developed clot, strength and stability. G value is a parametric measurement of clot firmness calculated from MA, and fibrinolysis at 30 minutes shows clot breakdown. The aim of our study was to determine hypercoagulability states in obese patients undergoing bariatric surgery using thromboelastography. We also aim to evaluate the potential of clinical and standard laboratory tests to predict hypercoagulability states in patients who had bariatric surgery. In our study, we included 60 consecutive patients undergoing laparoscopic bariatric surgery. There were assessed standard laboratory tests as well as thromboelastographic alterations at 4 time points, at baseline, immediately after the surgery, and at first and second postoperative days. We compared clinical characteristics and standard laboratory tests between two groups, normocoagulable and hypercoagulable. Hypercoagulability is defined as G value more than 11 and MA value more than 68. Only fibrinogen levels was significantly higher in both hypercoagulable groups. Also, in MA group, patients were significantly older. In this table, you can see dynamics of fibrinogen, D-dimer, and TEG values in perioperative setting. There was significant decrease in R time from baseline compared to values immediately after the surgery, showing the tendency to hypercoagulability. However, there was increase in R time from baseline levels to postoperative day 2, but it reached significant difference only in postoperative day 2. it could be related to the effect of low molecular mass heparin administered after the surgery. Other TEC parameters remained at similar levels. Also, there was significant increase in fibrinogen levels in postoperative D2 and D-dimer in both postoperative days when compared with initial levels. In order to evaluate the relationship between standard laboratory tests, clinical characteristics, and baseline TEC parameters, we performed correlation analysis. We did not observe any correlation between body mass index as well as markers of inflammation and any of TEC parameters. Fibrinogen levels were significantly higher in almost all, was associated with almost all TEC parameters, while D-dimers correlate only with R time. Interestingly, we also observed weak but significant correlation between age and R time, K time, and alpha angle. In order to assess potential predictive value of standard laboratory tests to predict hypercoagulability measured by TEC, we performed rock curve analysis. Only fibrinogen provide better rock curves. However, area under the curve showed only moderate predictive value with relatively low sensitivity and specificity. And to conclude, a considerable proportion of patients referred to bariatric surgery show hypercoagulability determined by TEC. This study shows the potential of hypercoagulation monitoring by TEC in perioperative setting of bariatric surgery. Plasma fibrinogen levels show moderate ability to predict hypercoagulation determined by thromboelastography. Thank you for your attention.
Thank you very much. I'd like to ask, why did you choose bariatric surgery? Because of it's easy to select these patients, or did you want to investigate especially bariatric surgery problems?
Yes, we aim to evaluate special bariatric surgeries because these
it's problem of bariatric surgery, yes. It's problem of obese patients?
It's problem, of course, of obese patients, but we wanted to have very strict criteria, only one operation, only one surgeon.
Yes, thank you. But did your study change practical guidelines of postoperative care management, some medication on some it, because results are very interesting? And did the surgeons change something in the postoperative course management?
Especially change the duration of operation, which is dependent to surgeon. Studies show that longer duration, longer than 3 hours, is associated with higher risk of thromboembolic events. And in our study, the mean duration of surgery was 91 minutes.
Yes, that means that you have to operate quicker, and there were no risks?
Excuse me? Quicker and?
There will be no risk for thromboembolism?
No, it's not.
Yes, I think it's also very important what we do with this knowledge, because we have to create guidelines for postoperative management to do. If patients have hypercoagulability, we should do something, not only quicker and faster, but it's very important, anticoagulant therapy, liquids, and so on.
All patients
Yes,
received low molecular mass heparins, and it's still open question if we should use adjusted doses of heparins, or is enough prophylactic doses is still open question.
So,
And guidelines, they didn't let's say, recommend the dosage. Only regimens in
yes, usually
general.
each hospital elaborates their own guidelines and using the practical. In each study in this field, as yours as well, will help to manage and to elaborate your own guidelines in the future. Thank you so much for presentation.
The next presentation is about efficiency of the new method of intra-abdominal transversus abdominis plane block in laparoscopic inguinal hernia repair. The topic will be delivered by Artūrs Trišenkovs.
Good afternoon, dear doctors, dear colleagues. My name is Artūrs Trišenkovs. I want to introduce to you efficiency of the new method of intra-abdominal transversus abdominis plane block in laparoscopic inguinal hernia repair. Laparoscopic inguinal hernia repair is a minimal invasive procedure. It's a day case surgery. Faster patient mobilization than open hernia repair. Less pain than open hernia repair. But pain is still the main post-operative problem. Moderate to severe, especially first post-operative day. Interfere return to daily activity. What is a transversus abdominis plane block? Is elective to decrease postoperative pain, but it's a time-consuming, technically challenging procedure, especially obese patients. And we need an ultrasonographic device. But what is INTAB? INTAB block is the method of transverse abdominis plane block under visual control during laparoscopically by a transabdominal needle. INTAB block easy to implement. No need ultrasonographic device, and 1 minute to perform this manipulation. In total, 60 patients undergoing elective laparoscopic transabdominal preperitoneal inguinal hernia repair were randomized in 2 groups. Test group, 30 patients in TAB block with 20 milliliters of 0.25 levobupivacaine. And the placebo group, 30 patients in TAB block with saline. In the postoperative period, pain and discomfort was assessed using a 0 to 10 visual analogous scale at 4 hours and analgesic consumption. There was no significant difference in age, ACS, body mass index, hernia size, and operation time in both groups. In test group, pain at 4 hours after operation was significantly lower. In the placebo group, we see that on the rest, patient had 3 points of pain, but in the test group, no pain. But on movement in placebo group, also 3 points of the pain, but in the test group, only, it's a median score, only 1 point. Discomfort level was significantly lower in the test group than in placebo group. respectively. On the rest only, in the placebo group, they had discomfort feeling on the 3 points. In the test group, 1 point. On the movement, the same patients, median score had 4 points of the pain, and in the test group, only 1 point. There were less needs for postoperative analgesic in test group in the placebo group, and no need for opioid injections in test group in compare with placebo group. So it's the better way than first one. The entire block is an effective method to reduce pain, discomfort, and the need for analgesic after the laparoscopic inguinal hernia surgery. Thank you for your attention.
Next question. Why did you choose 20 milliliters of anesthetic, not more or not less?
Because it's a better way to mix levobupropion with natrium chloride. How I can tell you? Concentration of levobupropion is better with 20 milliliters, not, for example, with 30 milliliters or more. It's concentration better, not less.
I can comment because I was inside this study, because it depends on how large amount we can inject in patients. Depends on patient body mass. Yes, we cannot inject more sometimes because patients have less weight. That's why it's median usually what we can inject in one patient.
And in both groups, this pain level was low, yeah, only 3 points. And why did you prescribe narcotics in such patients?
Yes, it was at 4 hours after surgery, but at night. Then at night, some patients need to be on this narcotic because pain level was higher.
No question.
So I would like to invite next speaker. Next speaker is topic CT role in preoperative evaluation of patients with peripheral artery disease undergoing elective surgery. Present Christiana Ulme.
Good afternoon, everyone. Today I would like to talk about my research paper on FFRCT role in preoperative evaluation of patients with peripheral artery disease undergoing elective surgery. So first of all, little about PAD epidemiology. In 2010, it was estimated that around 202 million people around the world were living with peripheral artery disease, and that every year around 400,000 inpatient admissions annually attributed to PAD, and the prevalence of this disease increases progressively with age. So the question is, why do we talk about this? A few years ago, a nationwide Danish study that included more than 100,000 patients with peripheral artery disease showed that these patients also have very high myocardial infarction mortality rates within 7 years, and also that more than half of PAD patients do not receive optimal medical management for coronary artery disease. So our hypothesis is that peripheral artery disease is a manifestation of generalized atherosclerosis, and that most of the PAD patients have asymptomatic coronary artery disease that has not been treated properly. So our research purpose is to detect prevalence and incidence of coronary artery disease in patients with peripheral artery disease in Latvia. So this picture has been taken from REACH registry that included more than 67,000 patients, and as you can see that most of these patients had coronary artery disease, second was cerebrovascular disease, and then there was peripheral artery disease. But in the middle you can see that these circles overlap, and it indicates that these patients had either 2 or all 3 of these vascular diseases, as they are all manifestations basically of atherosclerosis. It's very commonly that they all occur together. So materials and methods or research was a prospective study that was conducted at Paul Stradiņš Clinical University Hospital, and altogether 55 patients with PAD undergoing elective surgery were included. All these patients received coronary CT scan, and later the acquired data were used in heart flow FFRCT to evaluate patients' coronary arteries. So little about what is FFRCT or fractional flow reserve. So basically it is defined as the ratio across stenosis in an artery when it is maximally dilated, and usually it is done invasively. It is measured invasively during cardiac catheterization, but also it can be measured non-invasively using coronary CT scans, and then it is called FFRCT. So these pictures basically show how FFRCT is done. So first patient receives a coronary CT angiogram, and we get a patient-specific 3D anatomic model of patient's coronary arteries. Then there is patient-specific physiology model that we put all this data in this heart flow program, and in the result we receive a patient-specific 3D model of coronary arteries that also shows this FFR, which basically shows whether patient do have any significant narrowing in arteries. So this is taken from our research. As you can see, this patient has significant narrowing in his LAD artery as well as his left circumflexa. This is from different view, and this patient had coronary artery bypass grafting. So results from 55 individuals that were included, the mean age was 66 years, and 46 of the patients were men and 9 were women. 44 patients have hypertension, 9 patients have diabetes, but 18 of the patients are active smokers. So this graph shows action performed after we received the FFRCT results. As you can see in the green, or 43% patients did not have coronary artery disease. 25% of patients will receive coronarography. 7% of the patients have had coronary artery bypass grafting. 18% of the patients have had percutaneous coronary intervention, and 5% of the patients have received optimal medical treatment for coronary artery disease. So action for patients with proven coronary artery disease, as we can see, 40% of the patients had PCI, 60% of the patients had coronary artery bypass grafting, 32% of the patients haven't received coronarography yet, but it's planned to do so, and 12% of the patients have received optimal medical pharmacotherapy. So action after coronarography, as we can see, bigger half of the patients, or 58%, had percutaneous coronary intervention, 23% of the patients had coronary artery bypass grafting, and 70% of the patients received this optimal medical treatment. So our conclusions for this research is that most of the patients with peripheral artery disease, even without cardiac manifestations, have coronary artery disease. And as in the most of patients of coronary artery disease is asymptomatic, they do not receive adequate pharmacotherapy. And using a non-invasive diagnostic test such as FFRCT, it is possible to detect significant changes in coronary arteries and therefore lower the risk of cardiovascular events. Thank you for your attention.
Yes, I didn't understand. Is the PCI indicated in the case of asymptomatic coronary artery disease?
It is not indicated. for now, any surgery guidelines have not recommended it. It is not needed to basically do a deeper evaluation. But as we can see that most of the patients do have coronary artery disease, so this study is a bigger one. It will last for years, and maybe after it something will change and it will be recommended to do so, to do this FFRCT.
Because I think that nowadays it's we do it only in emergency cases, in infarctions and so on, active stenting and so on. But nevertheless, it was very excellent and interesting study, and thank you so much for that.
It's working now? I have a question according patient population, what you have, peripheral artery disease. It can be a asymptomatic patient, it can be a claudicant or critical limb ischemia. Do you have any evidence according what class of Rutherford are included in this study patient?
Thank you for your question. Unfortunately, I do not have. I just, the result was taken as global epidemiology. There wasn't any more details on that.
Yeah, because I believe that it's very important, because one group of patients is patient with a peripheral artery disease and critical limb ischemia. Another patient is a claudicant, according to peripheral artery disease. So, but nice. Very good results.
Thank you. If no more question, let's move forward. And the next presentation, the results of popliteal artery stent patency rates in association with preoperative and postoperative tibial runoff score. Aina Kratowska. Yes, Professor Ivanova.
Dear professors, dear colleagues, I am not Dr. Kratowska, I'm sorry of her. She is not able to be here today, but I will present her work. I am Dr. Patricia Ivanova, vascular surgeon, who work in the endovascular field in Riga East University Hospital. Today I will speak about our work, short-term results of popliteal artery long stent patency rates in association with perioperative and postoperative tibial runoff score. Popliteal artery has 3 segments and 3 runoff vessels, major runoff vessels: anterior, posterior tibial arteries, and peroneal artery. The popliteal artery is a common site of stenotic occlusion changes in patients with atherosclerotic peripheral artery disease. Not only historically, I can say, but even nowadays, it's a very tricky artery in treatment. And long time, it seems to be an artery who said, oh, it's better not to stent, it's better not to do an angioplasty, it's better to leave it or go for a surgery. But nowadays, when developing new technologies, new stents, it's more and more coming inside to have a popliteal artery stenting. Endovascular therapy, as I said, of popliteal artery are increasing because of appearance of dedicated popliteal stents. And of course, it's decreased perioperative morbidity, mortality risk comparing to the open surgery. Current studies are still controversies, whatever the number of tibial runoff arteries influences patency rents of long popliteal stent. Aim of our study is to assess short-term patency rates of popliteal artery stenting in association with pre- and post-operative tibial runoff score. Materials and methods, single-center retrospective case series studies. Inclusion criteria was popliteal artery stenting in 2015-2016, and total lesion length is more than 7 centimeters, and involvement of the P1 and P2 segment of the popliteal artery. As a descriptive, we take a patient gender, age, task, two anatomical segment lesions where are involved in the atherosclerotic process, Rutherford classification, and American Society of Anesthesiologists score. Preoperative and postoperative tibial runoff score, which actually is a system which our team was involving because we concluded in time of this study that the task recommendations for tibial arteries are not so punctual. And 6 months patency rates estimated by digital subtraction angiography or duplex ultrasound. Results, as we'll see, mean patient age was 74 years old, and more in study here is not written. I think it's more men than women, and to look of the anesthesiologist classification, it's 63% have an ASA 2 classification. If you look at the another descriptive parameters, then you see that for a task 2 classification according to tibial vessels, it's more type C, which is involved a lot in practically all tibial arteries. And to look of the clinical classification of Rutherford, you see that it's more category 4, 5, and as well 6. That means that practically patients are with a critical limb ischemia. About the system, what we involved, what we did, I can't speak so much today because it's in another publication which is still, we are working on it. But we made a special scoring system, and which means from tibial arteries that from point 0 to 6 it's weak runoff, from 6 to 11 it's medium, and from 11 to 15 it's good. And what we look on our patients is that 5,7 have a weak, a medium, preoperative tibial runoff score, and 7,71 is borderline medium. Results according patency, 7 patients lost in follow-up, and meantime repeated hospitalization, actually hospitalization is not treatment failure, was 77.3 days. And what we see in persons is that we clear out that 67% no hemodynamically significant instant lesions, and 33% have an occlusion or hemodynamically significant instant lesion. If you look to a result, according to correlation, regression analysis, then you see that actually there is no any statistically significant differences. So our conclusion is that long segment popliteal artery stenting in 6 months follow-up shows acceptable patency rates. As I said, this is different another literature data. And preoperative versus postoperative tibial runoff is weak versus borderline medium in patient with a long popliteal artery lesion. It's no statistically significant association in pre- and postoperative tibial runoff score, with popliteal stent failure was found in short-term results. But it could be explained with overall poor runoff of our patient category. The need of large-scale studies and longer follow-up periods should be performed to overcome possible influence of small patient numbers on statistical significant values. Thank you. Any questions?
Thank you very much. I have a question. What you will really do in your hospital? Will the stents will be better or scales will be better? Do you are you continuing tibial stenting now?
That is very important. As I already mentioned, it's a really description of the patients. Yeah, our patients from it's very poor runoff. It means that it's in the beginning it's patient selection as well. They are not go for surgery because it's poorer runoff and the bypass will not work for sure. And then they are get into the intervention. Like it's a last chance for these patients. Revascularize or not do anything. I believe that we will continue to develop.
Thank you. Yeah, thank you for a nice presentation, excellent presentation.
Thank you so much.
So the next presentation will be caloric intake evaluation in burn patients. Mara Melnalksne.
Good afternoon, everyone. And I'm Mara Melnalksne, and my presentation is going to be about caloric intake evaluation in burn patients. Critically ill burn patients are characterized by strong oxidative stress, an intense inflammatory response, and a prolonged hypermetabolic response. So the optimization of the nutritional support is essential for improving the outcomes in this group of patients. And also, an accurate serial assessments of nutritional status and body composition are central for identifying patient needs and efficiency of the care. And changes in lean body mass and body composition are ultimate reflections of the nutritional status. So the purpose for the study was to calculate the caloric needs of burn patients and to evaluate the actual caloric intake and the relationship between the caloric intake and different anthropometric measurements, total serum protein levels, and death rate between the burn patients in National Burn Center ICU. All the patients with burns were hospitalized between September 1st and December 28th, so they were enrolled in the study. And the study was approved by a local ethical committee, and the gender, age, extent of the burns, stay length in the ICU, caloric intake, total serum protein levels, upper arm circumference measurements, and skin fold thickness measurements were analyzed. And the caloric requirements for patients were calculated using two formulas, Harris-Benedict and Schofield equations. And the statistical analysis, it was made by SPSS 22 and GraphPad Prism, and a p-value of less than 0.05 was considered statistically significant. And a correlation coefficient, coefficients were calculated using Spearman's rank method. So the results. Together there were 21 critically ill patients with up to 40% TBSA and with a mean age of 62 years. And there were 48% males and 52% females. The mean stay in the ICU was 16 days. And the mean actual caloric intake was 1,780 calories, but calculated by Harris-Benedict formula, it was 2,947, and by Schofield equation, it was 2,191 calories a day. And so there were together four relationships found. The first one was between the caloric intake and the death rate in the ICU. Another one was between the total serum protein level on day 7 and also the death rate. And two more between the caloric intake and decreased skin fold thickness on the day 7, as well as the caloric intake and the decreased upper arm circumference on day 7. So the less the caloric intake, the more decreased the circumference was. And as a conclusion, there was a difference found between the caloric requirements calculated by these formulas and the actual intake in the hospital. And inadequate caloric intake in the patient with burns results in lower total serum protein levels, decreased thickness of skin fold measurements and upper arm circumference measurements, and also they have a higher overall death rate. Also, I should mention that measuring skin fold thickness and upper arm circumference could be a great method for assessing the nutritional status for the burn patients where weights cannot be used or they are simply not available. So, thank you for your attention.
Questions, please?
What can we do to improve actual caloric intake, practically?
Practically, no one really calculates these calories. I think the burn patient should have more calories. 1,700 calories, it's too much even for a normal walking person.
Means that it's poor kitchen or so?
Maybe, yeah. It's basically, yeah, the doctor is responsible.
That means wrong everyday calculation, yes? Or the calculation is do they take into account these calculations?
No, as I said, they don't calculate in the
They
ICU.
don't calculate
Yeah,
at all.
yeah. It's basically on the eye. They see how much they should give.
Yes, and one question is, thank you again for presentation. Question is, if we need more calories, what do you think we can do it enterally or parenteral? What do you think? Can patients tolerate enteral nutrition?
Enterally is the choice method, the best method. So parenterally, just when the gut is not ready to take it. Maybe.
So it's possible to take more calories by enteral nutrition, yes?
Yes.
99% of patients receive enteral route. Only few patients per year receive intravenous route.
Yeah. In one study there were.
But maybe would you explain? According to your presentation, I understand this calories was not calculated correctly, yeah?
Yeah.
But always it's possible to ensure this food intake.
No, it also depends on. No.
For example, I calculate correctly, but is it possible to perform this feeding?
When one really wants that, then I think yes, but it would be really hard. Like some patients eat by themselves, and then they should be fed more enterally, or yeah. And when he just don't want to eat, like what can you do with that? You can basically do nothing. I think it depends on the patient and on the doctor also. Yeah. That would be.
Thank you. Is there no more questions? Thank you for presentation. So, and next presentation is risk factors and manifestation in diabetic foot ulcers. Daina Kalniņa.
Good afternoon, dear colleagues, doctors and professor. My name is Daina Kalniņa. I am the 6th-year student of University of Latvia, and today I will tell you about risk factors and manifestation in diabetic foot ulcers. And before I start, I would like to thank my colleagues Sviatoslavs Kiskins, Dr. Cynthia Sauš, and Professor Arnold Dzizuko, who made this study come true. And the aim of the study is to evaluate lower limb amputation risk factors in hospitalized diabetic patients and compare with the rest of amputated patients group. And the task is to compare the risk factors of lower limb amputation in diabetes and non-diabetes patients, to evaluate the complication of diabetes mellitus, the frequency of amputation of diabetes foot due to wound infection, microangiopathy, and diabetes nephropathy, depending on age, gender, diabetes therapy, and seasons. Material and methods. In a retrospective cohort study data from 3 major hospitals was analyzed about diabetic patients who had undergone lower limb amputation in 2016. Amputation risk factors were assessed for diabetic and non-diabetic groups, paying particular attention to fasting blood glucose, chronic kidney disease, presence of wound infection, and bacterial spectrum. To compare categorical risk factors, chi-square test and Fisher exact probability test were used. Some words about pathogenesis. Hyperglycemia causes many biochemical imbalances in the body that eventually cause neuropathy, reduced tissue regeneration, and healing abilities. The pictures show two main pathogenesis pathways for the development of diabetes foot ulcers, progression of peripheral arterial disease over the years, and diabetic neuropathy. Eventually, most patients have neuroischemic lesion. Now I will talk about results. The distribution of patients between hospitals who had amputation of the lower limb in 2016. In total, there are 271 patients. Most of them are patients from Riga Eastern Clinical University Hospital. It's 213. In this chart, you can see that amputations are more often done to men. In total cohort, it is 167. Then women, where is 104. And more often, amputation patients amputations are patients after they are 65 years old. Causes of amputations. Only 5 patients with diabetes, the primary cause of amputation was peripheral arterial disease due to critical occlusion. The rest of patients, the most common reason for amputation was atherosclerosis. Arterial occlusion level. In proximal blood vessels, occlusion is more common in non-diabetic patients. In the distal blood vessels, there is a tendency to increase the number of diabetic patients. In the case of arteriopopliteal occlusion, it's 9 diabetic patients, and arteriotibialis, it is 24 diabetic patients. Amputation without vascular occlusion was performed in 60 patients with diabetes. And about osteomyelitis. Of all cases of osteomyelitis, amputation was done 32 patients with diabetes, it means 94%. Of all patients without osteomyelitis, 93 patients, it is 39% had diabetes, but 144, what is 60%, was non-diabetic patient. It means that osteomyelitis is more common in diabetic patients. In diabetic patients, chronic kidney disease was found more frequently. In particular, the 3rd stage. Diabetic patients often have diabetic nephropathy leading to chronic kidney disease. Bacterial prevalence. Percentage of bacterial spectrum in diabetic patients. Materials were taken from the foot ulcers and during foot surgery. In diabetic foot, isolates dominated Staphylococcus aureus, 35%, and Proteus, 18%. And in conclusion, I want to say, diabetic patients undergo foot amputations are more commonly due to distal occlusion in the arteries of the leg or osteomyelitis, infected diabetic foot ulcers. The risk of amputation of the lower limb is higher for men, and the most common pathogens in diabetic foot were Staphylococcus aureus, Proteus, and coagulase negative staphylococci. Thanks for your attention. Any questions?
Any questions in the audience, please?
How you investigate the patients? What segment of artery are occluded? Is it duplex? CT angio?
We used angiography with contrast.
in all patients was digital subtraction angiography?
Sorry, what was the question before?
How was it made an investigation of what level of the...
We make in question. Actually, I didn't include it here, but we just make that it's transfemoral, transtibular foot.
No, I understand, but what was the investigation methods used to say that there's a femoral artery occlusion? Or it was just palpate a pulse, or it was done a CT angio, or digital subtraction angio, or duplex scan?
We were scanning, wait.
Duplex in most of the patients.
Duplex, so no, okay, thank you.
So, any more questions?
If no more questions about amputations, let's go to the last presentation. It's optical 3-dimension scanning in assessment of soft tissue defects. Jānis Fredriksons.
Ladies and gentlemen on board, I'm pleased to present you with our research on potential use of 3-dimensional optical scanning in assessment of soft tissue defects. Skin and subcutaneous tissue wounds are generally directly observable, and diagnosis does not require additional methods. All diseases on the surface. However, there is an increased interest in use of objective photographic assessments, and the motivations for photographic methods are documentation, healing monitoring, and research purposes. In fact, in recent years, no study on these topics actually is done without objective assessments, generally through analysis of photographs. Digital image processing adds interest to photographic methods because photography is present for over hundreds of years, but the question is how easy you can use this assessment to be able to interpret results. So the question is not to gain photography, but to analyze it to get objective data. To be able to assess objectively extent of disease is important because in skin disease, extent predicts metabolic demands related to disease. It may affect treatment choice, and it affects mortality of disease. And healing rate assessment provides decision on adequacy of treatment, need to revise treatment, and mostly healing rate is basis to compare treatment modalities in studies, so it's academic tool. Photographic assessment of wounds has several limitations as photography is planar. In complex shapes, there always will be some parallax errors, and especially it relates to circular, semicircular wounds where half of wound is obscured for photographic assessment. Photography does not represent depth of wound, which is an important factor in predicting outcomes and healing time until final closure of the wound can be achieved. And photographic assessment always requires some introduced reference object to be able to later reconstruct for actual dimensions. There is a new methods which are rapidly developing as technology is developing. It's not developing mainly because of in field of medicine. It's robotic vision, augmented reality, etc. developments. But optical three-dimensional scanning is currently rapidly developing. So this technology has potentials to overcome these limitations which are attributable to photography. Currently, only a limited number of research articles has been published in use of optical three-dimensional scanning in assessment of skin wounds. Namely, at the present moment, I know two such research. Both are in previous 1.5 years. So I dare to prognose that the field is increasing. So objective of our study is basically to explore utility of optical three-dimensional scanning in characterization of skin wounds and healing monitoring. The main concerns why optical methods may struggle with skin wounds is live tissue peculiarities, especially that wound bed is generally wet surface, so it has specular reflectivity, which is not the best case scenario for optical instruments to work with. And the second is limited stability of samples, so you may not expect sample which you can assess for several times at the several settings the patient has. Movements, if you are going to do repeated scans, every patient positioning, in fact, will be unique. The technology, basically, what I'm speaking about is camera technology, which has added laser projector. How it works? The laser projects invisible to human eye reticle on a surface, and the camera observes this reticle from offset position. If the reticle is projected on uneven surface, there will be distortions of projected reticle, and then computer analyzes what is observed distortions and reconstructs the surface which may create such an distortion. And generally, the optical scanner has added one extra camera for work in visible spectrum to achieve information on color of the surface and to allow for work flow observation during scannings. This is one of recent main technology developments, so you may assess the size of instruments, so it's fully pocket capable instrument. It has been added to some commercially available laptop computers. Probably in near future, it may be added to pocket devices like tablet computers or mobile phones. As we are only gaining experience in using such a method, the first questions, of course, is to test validity and of the method to gain any meaningful results. So what is the main objective of this? this presented work is to work with tissue sample, which is close enough to what is meant to be the final samples. We made repeated scans of soft tissue defect model, namely pork belly. Those tissue defects were introduced, and it was reconstructed from scans to gain ideas on how the hardware will react to such a task. From tissue model, removed tissue volume was directly measured by immersion in saline, so displaced volume is corresponding to induced simulated tissue defect. Obtained scans were processed for wound surface area, actual area, and surface projection. What is the difference? Surface projection is a hole in the skin, what you observe. If a wound has some depression, it will have some extra area on lateral surfaces. Surface scan repeatability in fixed sample independent measure setting, it is to test technology's ability to give meaningful results in one single...
Sorry that I interrupt, but please go to results because you have only 7 minutes for presentation.
Yes. Results, linear dimension representation accuracy is 2%, which I will dare to call excellent in measuring living tissue. 2% accuracy is actually better that you may achieve by putting measuring device physically to the wound margin. Depth resolution in our study is 1.5 millimeter assessed at wound margins, which represents some large 11% relative error for full thickness subcutaneous tissue defect. That resolution may be improved by additional mathematical processing of model, but the model I currently see applies only to clean wound margins, which is not the case in most clinical situations. Rescan surface representation accuracy is 0.44 millimeters root mean square, so the device works with predictable results within half a millimeter, which is again better than you may achieve by physical measurement. Wound volume assessment is limited to what I call lost reference surface. The point is that when you have this skin and subcutaneous tissue defect, you already lost reference surface to what calculate actual tissue loss. So it must be reconstructed. It will be reconstructed with some assumptions. In this study, it is used nearly planar surface, which may be a good predictor for time to do skin grafting, but it will not regain the tissue to original shape. And in our study, we had several patients which had been scanned during treatment process. So there is one sample of osteomyelitis patient. The picture here is a tissue defect after excision of cutaneous fistula to second metatarsal, and this is superimposed image of state 3 weeks later after negative pressure therapy. And similarly, there is a patient with 3 successive scans after necrotizing erysipelas, 1, 2, and 3. So comparing these scans, we visually may gain some opinion on tissue defect. Thank you. So basically, the conclusions is 3-dimensional optical scanning has potential use in soft tissue wound assessment. In skin wound model, optical 3-dimensional scanning provides remarkable accuracy and excellent repeatability. Wound volume assessment is limited by necessity to use reconstructed lost surface. Further improved algorithms need to be developed for lost surface reconstruction, and manual processing of 3-dimensional scans for wound margin is labor intensive, so automated algorithms are to be developed. Thank you. This is
okay, any questions? It is a rather interesting topic, I think. Nobody has a practical experience in this field of investigation, but I think you will not stop in your activities, and after 1 year we'll see maybe more patients studied by this method, and congratulations. So we have finished our session, and I congratulate you all. You have done a great job. I wish you not to stop your studies, because scientific work will help in your practical activities and improve healthcare and improve your patients' survivals, and see you next year in such a session. Maybe professors?
Thank you for your attention.
Yes, that's it.